Think about the last time it woke you up. Not an alarm, not a sound from outside, not the kind of gradual surfacing from sleep that leaves you uncertain whether you actually slept at all, but the sudden, involuntary, searingly specific sensation of a muscle seizing in your calf, your foot, or the deep arch of your lower leg, with no warning, no movement that triggered it at 2 or 3 in the morning when the rest of your body was completely still. You know immediately what it is. You know because you have been woken by it before. You know because the pain is unlike any other pain that visits you during the day. It is a clenching, relentless contraction that does not respond to the first attempt to stretch it out, that does not ease when you stand, that leaves the muscle tender and sore for hours after the cramp itself has finally released. You reached down, you pressed your heel into the floor, you stretched your toes toward your shin, and eventually, after seconds that felt considerably longer, the muscle let go. You went back to sleep. You did not write it down. You did not mention it to anyone. You filed it, as almost every adult over 60 who experiences this does, under the category of things the body does with age that are unpleasant, persistent, and apparently without explanation. That category is where the most important signals the body produces go to be ignored. A nocturnal leg cramp in an adult over 60 is not what happens when you do not stretch enough before bed. It is not a quirk of sleeping position or mattress firmness or the particular angle at which your legs lay during REM sleep. It is not one of those things. A nocturnal leg cramp in an adult over 60 is a documented peripheral symptom with a documented list of underlying biological causes, several of which are serious, progressive, and entirely correctable. And the failure to connect the cramp to what is actually producing it represents one of the most consistently missed diagnostic opportunities in the primary care of the older adult population. Your muscles do not seize at 3 in the morning randomly. They seize because the precise biochemical environment they require to contract smoothly and release completely has been disrupted. And the disruption that produces that level of involuntary, painful, nocturnal muscle contraction does not resolve on its own, does not improve with age, and does not disappear simply because you have been living with it long enough to accept it as normal. Your body is producing the cramp for the same reason it produces any symptom, because something it needs is not present in the quantities it requires to function correctly, and the muscle, which is one of the most metabolically demanding and nutrient-sensitive tissues in the human body, is the first place that deficit becomes undeniable. The physiology of why muscles cramp and why they cramp at night specifically in a pattern that is so reliably nocturnal that researchers have given it its own clinical classification requires understanding the electrochemical machinery that controls every muscle contraction and every muscle release the body performs from the moment it wakes to the moment it sleeps and through the night when it should be resting. Skeletal muscle fibers contract because a nerve impulse triggers the release of calcium from within the muscle cell, and the calcium flood initiates the sliding of actin and myosin filaments, the structural proteins whose interaction is the physical basis of all muscular force. The muscle releases, relaxes. Because the nerve impulse stops, the calcium is actively pumped back out of the contractile apparatus by an energy-dependent mechanism that requires adenosine triphosphate, and the electrochemical gradient across the muscle cell membrane is restored to the resting state by the precise balance of electrolytes on each side of that membrane. Magnesium, potassium, calcium, and sodium must each be present in specific concentrations inside and outside the cell for that resting gradient to be maintained, for the nerve-to-muscle signal to fire appropriately, and for the release after contraction to occur completely. When any one of those electrolytes falls below the threshold concentration the muscle cell requires, the resting membrane potential becomes unstable, the cell becomes hyper-excitable, and spontaneous contractions, contractions that occur without any nerve signal initiating them, begin happening in the hours when the body's physiological buffers are at their lowest levels. Blood volume is reduced by the mild dehydration of overnight fasting, and the compensatory mechanisms that would mask the deficit during waking hours are offline. Dr. Robert Weiss, professor of medicine and director of clinical research at the Johns Hopkins Community Physicians Network, whose published work on electrolyte physiology and muscular disorders in older adults has appeared in the Journal of the American Geriatric Society, has written that nocturnal leg cramps in adults over 60 represent one of the most undertriaged symptoms in outpatient medicine, consistently attributed to nonspecific causes and managed with stretching recommendations, while the identifiable, measurable biochemical deficits producing them go undetected because no one ordered the blood panel that would have found them on the first visit. There are 5 specific deficiencies that account for the overwhelming majority of nocturnal leg cramps in adults over 60. Each one operates through a distinct cellular mechanism. Each one is identifiable by a specific blood test, and each one, once identified, can be corrected, not managed around, not stretched through, but corrected with interventions whose safety and effectiveness in the older adult population are among the most thoroughly documented in nutritional medicine. The first deficiency is the one that muscle physiologists and nutritional researchers consistently identify as the most prevalent, the most physiologically central, and the most systematically undermeasured in the 60-plus population, not because it is difficult to detect, but because the standard blood test used to assess it is, in a critical technical sense, the wrong test, and millions of older adults are being told their levels are normal by a measurement that does not reflect what is actually happening inside their muscle cells. Magnesium is the fourth most abundant mineral in the human body and the most important single mineral for muscle relaxation. It functions as a natural physiological antagonist to calcium. While calcium initiates the contractile cycle, magnesium is required to terminate it, blocking the calcium channels that would otherwise allow the contraction to continue indefinitely and enabling the muscle fiber to return to its resting state. When magnesium is insufficient, the contractile cycle does not terminate cleanly. The calcium channels remain partially open, the muscle fiber cannot fully relax, and the result, under the conditions of reduced buffering capacity and mild fluid depletion that the sleeping body creates overnight, is the sustained, involuntary contraction that wakes the person at 2 or 3 in the morning and refuses to respond to the first several attempts to stretch it out. Dr. Andrea Rozanoff, Director of Research and Science Information at the Center for Magnesium Education and Research, and a researcher whose work on magnesium deficiency and its clinical consequences has been published in the American Journal of Clinical Nutrition and Magnesium Research, has documented that dietary surveys consistently show over 60% of American adults consume less magnesium than the established dietary reference intake, and that the percentage is substantially higher in adults over 65, where reduced intestinal absorption efficiency, increased urinary magnesium loss driven by age-related kidney changes, and dietary patterns that exclude the magnesium-dense foods that whole grains, legumes, and dark leafy vegetables provide, combine to create a chronic subclinical deficiency that persists for years without being identified. The clinical complexity is this: the standard serum magnesium test, the one routinely included in basic metabolic panels, measures the magnesium circulating in the blood, which represents approximately 1% of the body's total magnesium content. The other 99% is stored inside cells, primarily inside muscle cells. A person can have a serum magnesium result in the reference range, while their intracellular magnesium, the magnesium available to the contractile machinery of the muscle, is severely and chronically depleted. If your doctor has tested your magnesium and told you it was normal, ask specifically whether the test ordered was a serum magnesium or an RBC magnesium, red blood cell magnesium, a measurement of the intracellular concentration, because those two tests are not measuring the same thing, and the difference between them may be the difference between a misdiagnosis and a corrected one. The second deficiency operates through an electrophysiological mechanism that connects nocturnal leg cramps to one of the most critical minerals in the entire cardiovascular and neuromuscular system. And that links a symptom most people experience as a local leg problem to a systemic deficiency with consequences that extend far beyond any muscle that cramps in the night. Potassium is the primary intracellular cation, the positively charged ion whose concentration inside the muscle cell is roughly 30 times higher than its concentration in the blood outside the cell, and whose electrochemical gradient across the cell membrane is the foundation of every nerve impulse, every muscle contraction, and every heartbeat the body generates. The resting membrane potential of the muscle cell, the electrical charge difference between the inside and outside of the cell that allows the contractile machinery to reset after each contraction, depends on the maintenance of that steep potassium gradient. And when potassium levels fall, whether through inadequate dietary intake, through chronic urinary losses, or through the pharmacological depletion produced by some of the most widely prescribed medications in the older adult population, the resting membrane potential becomes unstable, threshold for spontaneous firing drops, and the muscle becomes capable of generating its own contractions without any nerve input whatsoever. Research published in the journal Neurology, examining a cohort of adults over 60 with frequent nocturnal leg cramps, identified hypokalemia, low blood potassium, as a contributing factor in a clinically significant proportion of the study population, and found that correction of potassium status was associated with marked reduction in cramp frequency and severity in a subset of participants whose cramps had been attributed for years to nonspecific causes. The connection between potassium deficiency and the cardiac system adds a dimension to this discussion that elevates nocturnal leg cramps from a comfort concern to a potential cardiovascular warning. Because the same electrochemical instability that produces spontaneous contraction in a skeletal muscle in the leg can, under conditions of significant hypokalemia, produce spontaneous electrical firing in the specialized conduction tissue of the heart, generating the atrial and ventricular arrhythmias that are the most dangerous consequence of low potassium, and that are dramatically more common in adults taking the diuretic medications that deplete potassium as a direct pharmacological mechanism. If you experience nocturnal leg cramps and you take a diuretic, the blood test your physician needs to see is not optional and not routine. It is urgent. The third deficiency produces nocturnal leg cramps through a mechanism involving the same calcium that must be precisely regulated for normal muscle contraction and release, and it connects leg cramps occurring at night to a mineral deficiency whose downstream consequences for bone architecture, for cardiovascular calcification, for nerve signaling, and for immune function represent one of the most consequential nutritional shortfalls of the 60-plus decade. Calcium is the trigger mineral of muscle contraction, released from intracellular storage sites called the sarcoplasmic reticulum when the nerve impulse arrives, and it is also a structural component of the nerve membrane itself, where adequate extracellular calcium concentration stabilizes the electrical excitability of the nerve fiber and prevents the spontaneous repetitive firing that translates into the sensation of a cramp. When serum calcium falls, a condition called hypocalcemia that occurs most commonly in older adults through a combination of reduced dietary intake, diminished intestinal absorption, and the vitamin D deficiency that controls calcium uptake from the gut, the nerve membrane loses the stabilizing effect of extracellular calcium, becomes hyperexcitable, and generates spontaneous repetitive signals in the peripheral motor neurons that terminate on muscle fibers and drive them into sustained involuntary contraction. Research from the Journal of the American Geriatric Society has documented that subclinical hypocalcemia, calcium levels at the lower end of the normal reference range rather than below it, is sufficient to produce clinically significant muscle hyperexcitability in older adults whose neuromuscular systems have less functional reserve than younger adults to compensate for mild perturbations in mineral balance. The bone connection makes this deficiency doubly urgent. The same chronic calcium insufficiency that produces night cramps is, over time, withdrawing calcium from the skeletal reservoir of the hip, the spine, and the wrist that determines fracture risk in a fall. And the fall that breaks the hip is frequently preceded by months or years of nocturnal leg cramps that were attributed to everything except the mineral deficiency, producing both the cramps and the bone loss simultaneously. A corrected calcium level is not two separate treatments for two separate problems. It is one correction that addresses both. The fourth deficiency does not directly produce the cramp through its own absence the way magnesium and potassium do. It produces it indirectly through its control of a hormonal and cellular cascade whose ultimate downstream failure is the calcium and magnesium depletion that the muscle experiences when the night cramp begins, making it the silent upstream cause behind a symptom whose immediate biochemical mechanism points at other minerals but whose root regulatory failure points squarely at this one. Vitamin D, more accurately a hormone precursor than a vitamin, produced in the skin from sunlight exposure and activated by the liver and kidneys into its biologically active form, calcitriol, regulates the absorption of calcium from the small intestine, governs the retention of both calcium and magnesium by the kidneys, and binds directly to vitamin D receptors present in skeletal muscle cells, where it regulates the expression of the proteins involved in calcium transport across the muscle membrane. When vitamin D is deficient, calcium absorption from food and supplementation falls regardless of how much calcium is consumed, because the intestinal machinery that transfers calcium into the bloodstream requires activated vitamin D to function. Simultaneously, the muscle cells themselves lose direct vitamin D signaling, producing a state of impaired calcium handling within the contractile apparatus that manifests as weakness, fatigue, and the predisposition to cramps that has been documented in vitamin D deficient patients across multiple clinical studies. Dr. Michael Holick, professor of medicine, physiology, and biophysics at Boston University School of Medicine, and the researcher whose work on vitamin D and musculoskeletal health has been published in the New England Journal of Medicine, the Journal of Clinical Endocrinology and Metabolism, and the American Journal of Clinical Nutrition has documented that vitamin D deficiency affects an estimated 70 to 80% of adults over 65 in the United States, a proportion that rises in northern latitudes in individuals who spend little time outdoors and in adults with darker skin pigmentation, because each of those conditions reduces the cutaneous synthesis of vitamin D from sunlight exposure. A 25-hydroxyvitamin D blood level, the standard test for vitamin D status, costs almost nothing, is available at any laboratory, and can identify a deficiency that has been producing muscular symptoms for months or years while being attributed to everything except the hormonal deficit controlling the mineral environment the muscle requires to function without pain. The fifth deficiency is the one that the 60-plus population is most consistently warned about in the most general terms and least consistently protected against in the specific, physiologically meaningful way that would actually prevent the nighttime cramps it produces, because the advice to stay hydrated, though universally given, almost never includes the explanation of why dehydration produces cramps through a mechanism that is distinct from simple fluid loss and that cannot be corrected by drinking water alone. The relationship between dehydration and nocturnal leg cramps is not primarily a volume relationship. It is an electrolyte concentration relationship. When the body loses fluid, the concentration of all dissolved minerals in the remaining fluid changes, and the sodium-to-fluid ratio in the blood and interstitial tissue rises in a pattern that alters the osmotic environment surrounding the muscle cell, drawing water out of the cell, shrinking it, and increasing the relative concentration of intracellular minerals in a way that destabilizes the resting membrane potential and heightens the muscle's susceptibility to spontaneous contraction. Older adults are particularly vulnerable to this mechanism because the thirst signal, the subjective sensation of thirst that drives fluid intake in younger adults, progressively diminishes with age in a well-documented phenomenon called hypodipsia of aging, leaving adults over 65 consistently underhydrated without any awareness that they are. A study published in the Journal of the American Geriatric Society found that a significant proportion of community-dwelling adults over 65 were in a state of chronic mild dehydration, measurable by urine osmolality and serum sodium concentration, despite reporting no subjective sensation of thirst, meaning they were dehydrated, their muscle cells were operating in a suboptimal electrolyte environment, and they had no internal signal telling them to correct it. The sodium component of this mechanism is the piece most commonly overlooked in the hydration conversation. Sodium governs the distribution of water between the blood, the interstitial space, and the intracellular space, and in older adults on sodium-restricted diets for hypertension management, a population whose dietary sodium restriction is appropriate for blood pressure control, but whose mineral balance requires careful monitoring. The combination of low dietary sodium and high fluid intake without mineral replacement can push the intracellular electrolyte environment toward the imbalance that produces cramps more effectively than mild dehydration alone. Hydration that prevents nocturnal leg cramps is not water. It is water carrying the minerals the muscle cell needs to maintain its resting equilibrium through the hours of sleep. There is a pharmacological layer to this discussion that belongs specifically to the large proportion of adults over 60 managing chronic conditions with daily prescription medications, because some of the most widely prescribed drugs in this population produce nocturnal leg cramps not as a rare adverse event listed in fine print, but as a predictable direct pharmacological consequence of their mechanism of action, operating through the same mineral depletion pathways that the previous sections of this discussion have described, and doing so in patients who have been cramping for months or years without ever being told that the medication in their medicine cabinet is the cause. Statins, including atorvastatin, prescribed as Lipitor, rosuvastatin, prescribed as Crestor, and simvastatin, prescribed as Zocor, are the most widely prescribed class of medications in the cardiovascular risk population, and they produce muscular symptoms including cramps, pain, and weakness in a documented proportion of patients through a mechanism that involves the depletion of coenzyme Q10, a mitochondrial enzyme critical to energy production in muscle cells, whose synthesis pathway overlaps with the cholesterol synthesis pathway that statins inhibit. Research published in JAMA Internal Medicine examining statin-associated muscle symptoms found that muscle pain and cramps were the most commonly reported adverse effects in statin users over 65, that they disproportionately presented nocturnally, and that they were frequently attributed by both patients and physicians to age-related musculoskeletal changes rather than to the medication producing them. Thiazide diuretics, including hydrochlorothiazide, the most widely prescribed antihypertensive in the United States, and loop diuretics, including furosemide, prescribed as Lasix, produce potassium and magnesium depletion as a direct pharmacological consequence of their mechanism. They block tubular reabsorption of sodium in the kidney, and the compensatory hormonal response to the resulting sodium and volume loss increases urinary excretion of potassium and magnesium simultaneously, creating the precise deficiencies that produce nocturnal leg cramps, while the patient believes their blood pressure is being controlled and nothing else in their physiology is being affected. The most profound clinical irony in this discussion is that the medication most commonly prescribed to the population most affected by nocturnal leg cramps is one of the most reliable producers of the mineral deficiencies that cause them. A patient on hydrochlorothiazide who cramps at night is not experiencing two separate problems. They are experiencing one pharmacological cause expressing itself as a cardiovascular treatment on one side and a nocturnal symptom on the other. The connection between those two things should be the first sentence in the prescribing conversation, and in most cases, it is never spoken at all. Here's what to do with everything you now understand, because the cramp you have been living with, the one that has been waking you at 2 in the morning and fading before you could decide whether it was worth mentioning, has not been random and it is not inevitable, and the fact that you have been experiencing it for months or years does not mean it will require months or years to correct. Begin with the blood panel that can answer most of this in a single morning's laboratory visit. Request from your physician, by name, a red blood cell magnesium level, not a serum magnesium, which will tell you almost nothing useful, but an RBC magnesium, which measures the intracellular concentration where the deficit actually lives. Request a comprehensive metabolic panel that includes potassium and calcium. Request a 25-hydroxy vitamin D level. And if you take a diuretic or a statin, request those tests with the explicit framing that you are evaluating whether your medication is contributing to your nocturnal symptoms, because that framing will produce a different quality of clinical attention than a complaint about leg cramps at night. When the results come back, if your RBC magnesium is below the optimal range of 5.5 to 6.5 milligrams per deciliter, ask specifically about magnesium glycinate or magnesium citrate, forms of magnesium whose intestinal absorption in older adults is significantly better than magnesium oxide, the cheap, poorly absorbed form found in most mass-market supplements, and ask whether Slowmag, a magnesium chloride formulation in a slow-release tablet designed specifically to reduce the gastrointestinal irritation that higher-dose magnesium supplementation can produce, is appropriate for your situation. If your potassium is in the lower portion of the normal range and you are taking a diuretic, ask your physician about potassium replacement and about whether a potassium-sparing diuretic such as spironolactone might be a clinically appropriate modification to your antihypertensive regimen. If your 25-hydroxy vitamin D is below 50 nanomoles per liter, a threshold that a substantial proportion of adults over 65 fall below, ask about vitamin D3 supplementation because D3 is the form with the most robust clinical evidence for raising blood levels effectively in older adults, and because the dose required to correct a deficiency is typically higher than the 400 international units found in most multivitamins. Begin drinking fluids earlier in the day rather than concentrating intake in the evening, because evening fluid loading increases nocturnal urination without improving the overnight hydration status that matters for muscle function, while morning and afternoon hydration with mineral-containing fluids, not plain water, which dilutes rather than restores electrolyte balance, provides the ionic environment the muscle cell requires through the sleeping hours. Write down how long you have been cramping, which muscle groups are involved, what time of night the cramps typically occur, and whether they have been worsening, because that document, specific and dated, gives your physician a clinical picture that a vague mention of leg cramps at the end of an appointment cannot. The cramp that woke you has a cause. The cause has a name. The name has a correction. And the only thing between where you are right now and a night without pain is a blood test, a medication review, and a physician who now has the specific vocabulary you are equipped to provide.